Ready? Okay, welcome everyone to the second year that we're co-hosting with the TerryFox Run a medical forum. Can you hear me well? Is this loud enough? Yes? Okay. I'll start by introducing myself. My name is Amélie Dion Charret. I'm from Montreal, so I'm Canadian, and the TerryFox Run and its foundation is something that is very close to my heart. I have been living in Hong Kong for 5 years. I am a lawyer by training, and I'm specialized in medical law. Yes, it's a specialty that exists. And I, by accident, became entrepreneur, and 5 years ago, I created 2 companies in Hong Kong, both in the health space, AD Medilink and Healthy Matters. So today it's Healthy Matters that is co-hosting the medical forum, and Healthy Matters in Hong Kong provides trusted health information to the public. And we do that through events, online content, as well as a book that we published on pregnancy and babies. I'm honored, Dr. Lam, to be speaking with you for a second time. We met last year. And just to tell you how things will be run for our talk, I will start by introducing Dr. Lam. I will ask questions that I have personally. I also have a list of questions that were submitted by students from Renaissance College, but other schools. So I will ask a few questions from them, and I will open it to you so you can ask questions, all right? And it should take about, we need to be done at 1 o'clock, so we have about 50 minutes of discussion with Dr. Lam. So Dr. Lam, you are a clinical professor at the University of Hong Kong and a specialist in respiratory medicine, and you practice as a doctor at Queen Mary Hospital. So you are a respiratory physician, and I'm going to read your bio here, but you will have to translate that and make it simple to us. So you're a respiratory physician doctor with an interest in translational research and clinical trials in respiratory diseases, including lung cancer. And I think it's important to say that today we are raising money for a research project that you're working on, which is specifically geared towards lung cancer. And so we look forward to learning more about that. And your research focuses, again, on translational, but you need to explain that to us, research with biomarkers in lung cancer and airway. So you practice as a doctor, you are a professor and researcher. Can you explain in simpler words the research project that you're working on? It's extremely important to us because this is the reason why people are running today, why we're raising money. So can you translate that and tell us what the research project is all about?
Oh, thank you, Emily. Actually, if I can say in simple terms, I'm a practicing medical doctor taking care of patients with respiratory diseases, including lung cancer. And we have other airway diseases like asthma and COPD. But my research focus, because in the university-affiliated hospital, as university doctors, we have the mission of not only treating patients, but doing research to advance our knowledge in a specific areas of medical field. And I've chosen lung cancer. And I see different kinds of lung cancer patients every day. Different kinds meaning different types of lung cancer and people at different stages of lung cancer. And as a researcher, I'm also running research projects on lung cancer. And being a clinical doctor, we have the scarce opportunity to be in touch with our patient, and at the same time of treating them, we can try to see if we can bring new therapeutics and also diagnostics to the patients, and that where we comes in the research projects of biomarkers and also for early detection and treatment of lung cancer. Now, take it as an example, with the support of TerryFox Run Hong Kong last year, we have started a project in collaboration with overseas universities with my colleagues at the University of British Columbia and also University of Queensland to start an international multi-center projects to cover subjects from different geographical areas, including Canada and also Australia, and also we ourselves in Hong Kong. And we have set up the projects to target screening of lung cancer. That means early detection of lung cancers in a targeted population of subjects, and we're targeting smokers who are current smokers or what we call ex-smokers. And also they have specific risk factors that we have assessed. And then we invite them for this screening trial, and they will undergo what we call a low-dose CT scan of the chest to see if we can find lung cancer at an early stage as early as possible. So that's one project that is currently up running in Hong Kong. And as you have heard from Emily, that I'm running also other research in the university. And besides seeing patients, I also run a research lab where I would also help to check the so-called biomarkers in lung cancer. And you may have heard people on targeted therapy, right? And we are doing research on those biomarkers that will guide us towards targeted therapy or even immunotherapy. We are doing research on those areas, and I must say I'm not the only researchers in my university, and I usually work with other researchers in the university and in the clinic and in the hospital, and looking after patients on lung cancer and also getting biomarker research. A lot of the times we have clinical specimens from the patients that we try to study the individual patients' specimens, and in order to understand the disease better and to do laboratory research also.
So you specialize in lung cancer, and there's so many cancers that we hear of today. Can you tell us more about lung cancer, the landscape in Hong Kong? How is it different than other cancers? Are there any specific challenges to lung cancer if we compare it to colon cancer, for instance?
I see. Lung cancer used to be the most common cancer in Hong Kong. Mm-hmm. But if you listen to the news in recent days, the commonest of lung cancer has just been surpassed by colorectal cancer. So colorectal cancer is right now the most common one in Hong Kong. But the so-called surpasses, the difference between the numbers in colon cancer and lung cancer, the difference is within 100. So you may say colorectal cancer had just surpassed lung cancer, but lung cancer is still one of the common one. And also we talk about what we call mortality. That's the death rate from a certain cancer disease. Lung cancer still tops the mortality.
Why? Why is that?
Probably because a lot of the times we diagnosed lung cancer or patients present with lung cancer at an advanced stage. And we usually, as physicians, receive referral for patients who present with various symptoms that leads to eventual diagnosis of lung cancer. But indeed, a lot of them, when they present with symptoms, that already means that they have, unfortunately, the disease at a relatively advanced stage. So that's why we always hope to see if we can try to find these cancer early. And by finding these cancer early, there is always a better chance that the disease can be cured by removing the cancer. But when we diagnose the cancer disease at advanced stage, a lot of the times they have spread to different parts of the body. That means they cannot be removed by simple surgery, and we have to rely on medical treatment that you may have heard about: chemotherapy, targeted therapy, radiotherapy, and nowadays immunotherapy. So you will hear about these different options, but a lot of the time, these options will not be so-called curative. That means they will not be able to cure the disease or remove the disease completely from our patients. A lot of the times, however, we now have these different options to help to control the disease. So cancer survivors nowadays live far longer than we used to see them. And but having said that, we will still aim at, if there is a chance, to try to screen for subjects and to aim at cure the disease in the early stage, if there still can be removed or resectable.
I think everyone is aware of the correlation between smoking and lung cancer. But another hot topic in Hong Kong is pollution. Is there any evidence today that pollution levels can trigger cancer, lung cancer?
We always suspect that, and it's one of the objectives of our project, because it's a multi-center one, to see what's the level of pollution, how's that correlated or affect the detection rate of lung cancer in this locality. And we always believe that the air pollution or pollution of whatever kind in food may contribute to the development of cancer disease, but we are not able to decipher the exact contribution yet. So that's why we are still researching on to see what kind of contribution it is. But for lung cancer, it still remains one significant contributory factor, and indeed, we call it causal relationship, as tobacco smoking is so prominent. So that's why we are running that screening project right now in our center, and we're targeting smokers, both smokers and current smokers or ex-smokers, and we're taking this opportunity to ask them to stop smoking if they're still current smokers, and if they have quit, we ask them not to start smoking again.
Okay. I will move on to the questions that the students submitted in advance. So I have a question from a student here at Renaissance College. Do you believe, so this is a very broad question, okay, but several students asked this question. Do you believe that cancer can be cured? Can we hope for it to be cured one day?
I see. That's a very broad question. If I would say, if you ask for my personal belief, I do believe that the cancer can be cured one day. Okay, but we have different types of cancer. Different types of cancers is actually far from that target at a different distance. For example, in other types of cancer like leukemia, certain forms of leukemia, in the past we also believe that it's a kind of a blood disease, blood cancer that is not curable. But nowadays we have strategy to target special types of leukemia. I must say not all, but for certain types of leukemia we can treat them, and then after the disease has gone into remission, then we go for bone marrow transplantation, and then the disease, would be a high chance for cure. And we have a lot of survivors who have undergone bone marrow transplantation for previous treated leukemia and cure of the disease. So it may also happen in other forms of cancer, in different types of cancer. Lung may be just one of them, but at the present moment, still we would like to convey the message that do not stop smoking, which is a significant causal factor for lung cancer.
For lung cancer. I was mentioning that you see patients also at the Queen Mary Hospital, and we have a question again from a student at Renaissance College. Could you share with us a story about a memorable patient? and why he or she is unforgettable.
I see. Well, I must say I've been practicing for almost 20 years, and with almost 15 years of history of treating lung cancer. I would say all the patients are quite memorable to me. They have different individual stories. But if I can share with you one of them, is actually my secondary school teacher. That one day I got a ring from his son. His son is also a doctor who has been following me as a houseman. You know houseman? That's fresh graduate under first year of training. And his father, actually my secondary school teacher, has got some problem and would like to see if you can help him. And then of course, he's my teacher. Starting from the diagnosis, that means as a respiratory physician, trying to get the correct diagnosis with respect to the type of tumor, and also then test for the different markers for him. Unfortunately, he hasn't got any specific markers that will guide targeted therapy. So at that time, that was actually just a few years back, and he has to be put on a chemotherapy because of the so-called advanced stage disease of lung cancer. He's not a smoker, and he has been fighting on for 3 years under my care, initially with a very good response to chemotherapy. So you can see the difference when we were young, when I was a kid. When people get lung cancer, they survive for just a few months. But nowadays, people even on chemotherapy can have the disease in control for a few years. And he managed to fight for the cancer for 3 years, maintained on monthly treatment with relatively good quality of life, and his other son managed to come back from the United States to visit him regularly, and but unfortunately, and the usual story, after 3 years of on treatment, he progressed further, and at that time, the immunotherapy comes in, and you may have heard about the immunotherapy. And he is among the first batch of my patients who has been put on immunotherapy.
Can you explain what it is?
Yeah, the immunotherapy, I can try to explain to you later. Unfortunately, he finally did not survive the treatment after a few courses of immunotherapy, and passed away. So it's touching in the sense that I was sitting in his class when I was a Form 2 student, and I did not expect that. But as doctor, you're bound to have some life experience that is not very forgettable. Okay, and talking about immunotherapy, you may have heard about it as a new form of treatment for various different types of cancer, not limited to lung cancer. But I will say it again, immunotherapy is a broad term. Okay? It kinds of includes different types of therapy. You may have heard about tumor vaccine. Tumor vaccine is one form of immunotherapy that you try to take the patient's immune cells, that's the white blood cells, to take out and try to use some method to train the white cells, and then you inject the white cells back into the patient to help to try to boost up the immunity of the white cells against cancer. Now that's one form that hasn't received any success in the medical field yet, so it's not in practice, but it's just one form of immunotherapy if you talk about research. The other forms that we are now using for patients in practice is what we call immune checkpoint inhibition. Immune checkpoint inhibition is to use what we call antibody. Antibody is a substance that you can use to inject into the patient, and that will bind to a certain receptor, antibody receptor on the cells, binding, to tell the cells to do different things. Now, immune checkpoint inhibitor this time is to use a monoclonal antibody to try to bind on a certain receptor. That receptor is either present on the tumor cells, the cancer cells, or what we call the T cells. Now, that may be too difficult a concept for you. If I can explain to you in more simple terms, take an analogy that cancer cells are criminals, and in every patient in the body, in everyone, there is the T cells. That's the police. That's your immune system. The police is supposed to be able to find the criminals and arrest the criminals at least, or if it is the immune cells, to kill the cancer cells, right? But the cancer cells know the tricks. The criminals know the tricks. They put up a receptor on their surface. That means they wear a clothes. And that clothes, when they're in contact with the immune cells, when they're in contact with the police, they will tell the police, go away. And best, police, please commit suicide. Okay? So they will ask the white cells to go away or to die. Now, the immune checkpoint inhibitor in the form of immunotherapy is trying to block this communication. That means blocking the cancer cells to tell the T cells to die, thus preserving the T cell functions as a police to kill the tumor cells. So that's very, I hope that will be a simple analogy for you, okay? And in clinical practice, it's not 100% success, okay? Although it offers a new option for the patient on top of chemotherapy and targeted therapy, and I'm sure it will become part of the standard of care in the future for management of different cancer, including lung cancer, liver cancer, or other forms of cancer. But it's not 100% success. What we call the response rate in patient is not 100%. We do not know why at the moment, but we believe that cancer cells are living cells. They try to manipulate different way. If we take that analogy again, whenever they see police, they put on a different clothes. They stick out other receptor, okay? So, and thus avoid the arrest by the police while working on the other way to grow further, okay? But we do see effects. That means this binding is blocked in some way. It does help. So it remains a manageable option, a usable option for patients with lung cancer.
So you mentioned that immunotherapy is a new option in addition to other treatments, but can it be used simultaneously with chemotherapy, or you have to choose between the two options, one of the two?
There are different clinical trials coming up. Usually the development of drugs is like that. Usually we first try in clinical trials, we first try the new drugs in what we call second-line setting. That means they have failed the standard of care. And we have found that immunotherapy is effective as a second-line treatment for patients with lung cancer. Now, clinical trial data are coming out to support that it's going to be useful for patients in the first-line setting. If you use it alone, then you have to make sure the tumor or the cancer cells express that receptor. That means they wear that clothes before it will be effective. And data are also coming out for lung cancer that this can be used in combination with chemotherapy. but not targeted therapy. And also, and again, it has to be in cancer cells that wear that clothes that express the receptor. Otherwise, it may not be that effective. And it is in other areas of research that you may have heard about targeted therapy. Targeted therapy is that if you take the cancer cells to a test, then you can find certain genes that are mutated, that are changed, what we call gene mutation. If the certain cancer cells were found to carry a specific type of gene mutation, then there are targeted therapy that will help to kill that cancer cells. One prominent example is EGFR. You may have heard about or seen it on the web. That's epidermal growth factor receptor. And I don't know whether it's fortunate or unfortunate that in Asian, in this locality, we have a high proportion of patients with EGFR mutation. And that's why you may have heard about patients taking targeted therapy. That's oral drugs instead of injection. That's EGFR targeted therapy. And it's also interesting, that's why we do research nowadays, that in patients who have EGFR mutated tumors, that amounts to 40 to 50% of the lung cancer among our local population of patients with lung cancer. They should be treated with targeted therapy, of course, but if they fail the targeted therapy, remember I said immunotherapy can be tried in second-line setting. It seems to us that those tumors, those cancer with a target or a targeted mutation will have a less than optimal response to immunotherapy. And there's another proof to us that cancer cells are indeed dynamically growing. They just adapt to the environment and adapt to your treatment. So that's why we have to keep on our research into new biomarkers, new treatment for hopefully a better treatment option and in the end a cure for the disease.
I have another question from a student here at Renaissance College. How, and this is more about practicing medicine in general, how important is it to speak Cantonese as a doctor? And if I want to be a doctor and my Cantonese is not so good, is that possible?
I see. That's indeed a very common question. And in our university, if you want to apply for admission to study medicine, you have to go through interview, right? And we have set the criteria that some questions may be asked in Cantonese, and indeed that reflects our wish to have doctors who can speak Cantonese. But we are not testing your Cantonese. We are not asking people to speak Cantonese very fluently, but at least be able to communicate to patients. So our aim is to have doctors who can communicate with patients. Cantonese may not be the only means, okay? But simple communication will do. Just like in my experience, when I was students, you know, before 1997, we don't have a chance to learn Putonghua. But nowadays, we are seeing a lot of patients who speak Putonghua, even from local population, not necessarily patients from mainland China. So I must say, knowing Cantonese, being able to speak in Cantonese will be facilitating to doctors under local practice, but just simple one will do. We're not asking you, nowadays people have to manage different languages.
So does this mean that medical school teaches in English and that medical records are in English?
Yes.
Okay.
We're still running the system of teaching in English. All the lectures are conducted in English as well as tutorials. And the medical records nowadays, when you go to a public system, a hospital authority clinics, you see doctors typing while seeing doctors, we're still in English.
I'd like to take some questions from the audience. Is there anyone that would like to ask a question? Yes?
What actually you say those smokers are prominent with lung cancer, so what is the percentage actually when you in Hong Kong you learn cancer patient? How many of them are smokers? 50%, 60%, 70%?
So it's, sorry,
I would like to know the percentage of smokers, people who have lung cancer.
Among the patients that have lung cancer, what percentage are smokers?
We don't have a good going statistics locally because we have in the past the public system has difficulty in getting accurate smoking history. Even in overseas centers, sometimes the smoking history a lot of the times are self-reported, and is really interested if you ask the general public, are you a smokers? So in the future, if you're doctors, in my life, I ask a lot of patients, are you smokers? And they say, no. But if you ask in detail, have you been smoking in the past, even though you are not smoking now? And they say, yes, I have been smoking at teenage. Okay, so they are actually ex-smokers. But I would just say it's special in this part of the world compared to Western countries. For example, in the United States or in Europe, the prevalence of smoking in patients with lung cancer, if you talk about man to woman ratio, in the West is 5 to 6 men to 1 woman. But in this locality of the world, in this part of the world, what we say, Hong Kong, Taiwan, and southern part of China, the man to woman ratio is almost 2 to 1.
Why is
So,
that?
We don't know why. And a lot of the women are non-smoker. So we always tell our students, male smokers is still the major portion in patients with lung cancer. Do not get away with the concept that woman has more lung cancer in this part of the world. No. But we do see a prominent group of female non-smokers in this part of the world. We don't have the exact numbers, and yet we don't know why. Is that maybe pollution, maybe food, okay? So what we usually say, the message is do not smoke. And even if you are women or females, also do not smoke, because in fact, females or women may be more prone to develop cancer, even without smoking. So that's why just avoid it first. We don't know why.
Talking about smoking, in Carrie Lam's policy address recently, she openly said, the chief executive, that e-cigarettes would not be sold in Hong Kong. And there are two sides, two opinions, right, in terms of e-cigarettes. Some argue that they should not be sold and promoted because young people and teenagers can have access to them and it's bad for their health. Gateway, whereas others argue that it's the lesser evil and therefore should be sold to completely eliminate cigarettes. What is your opinion on this?
Well, I must say clearly that all these types of cigarettes, no matter it is electronic cigarettes or the heat not burn cigarettes, they should all be banned and should not be allowed, okay? And first, we have found that although all these products, the electronic cigarettes or the what we call heat not burn cigarettes, a lot of them say that there is no nicotine, especially the electronic cigarettes. They said the ampoules that you put into the electronic cigarettes are nicotine free, so you won't get addicted. But with testing, most of them indeed were tested to have nicotine. Okay? So we have just no way to know whether those products being sold actually are similar to tobacco products or not. Now, heat not burn cigarettes. Okay? Heat not burns meaning that almost like you are heating up the cigarettes, but you do not suck them. Okay? You just breathe in the flavor that is burnt from the cigarette. It's still cigarettes, okay? You have heard about heat not burn cigarettes, okay? So these are all cigarette we consider similar to cigarette products, and the hazards are still we consider the same. And we all know about the gateway effect. What we call gateway effect is that once anyone, especially teenager, who have got access to it, has got the wrong belief that it's not harmful and take it as easy products, and then that will loosen their mind towards the threat of this kind of cigarettes or even true cigarettes. And a lot of the times they have that threat in their mind lessen, and a lot of the time we are afraid that they will go on to true cigarettes. And there are some people or some advocates who say that these are not harmful and may just provide another method, safe, so-called safe method to stop smoking for smokers. They can switch from traditional cigarettes towards e-cigarettes or the heat not burn ones, and saying that is a means for them to lessen the harm from a one that is definitely harmful to a one that is potentially less harmful, to help them to stop the smoking. Now, in actual fact, in real life, I've never seen that. Okay, I've been running the smoking cessation clinic myself. People have been taking electronic cigarettes, saying that they will switch to electronic cigarettes, and eventually either they're maintained on electronic cigarettes or switch back to the true cigarettes. Okay? Well, this is my personal experience, and in fact, we have no good going evidence from research that this electronic cigarettes actually helps people to quit or document them to quit. So it's just provide another, we believe, another excuse for people to keep on smoking. And so we always ask people to stop smoking at once, no matter how hard we try. It's a matter of determination, okay? And always we ask young people not to stop smoking, not to start learning how to smoke, okay?
Other questions? Yes?
If you diagnose lung cancer early in the early stages, is it possible to cure it with surgery?
Sorry, I can't hear you well.
If lung cancer is diagnosed at an early stage, can you cure it through surgery?
Yes, that's what we are aiming at, because lung cancer right now, if you diagnose that in the early stage, if you found it in the early stage, what we call stages 1 and 2 lung cancer, they are usually localized as a single nodule or just a little bit of spread. Then the best way to cure it is to take it out.
So it's like a tumor, right? Just take out a tumor.
Sorry.
It's like a tumor. Is it like a tumor?
Yes, it's called a tumor. You're right. It's a tumor.
The percentage of the mortality rate of the surgery? Like, is there a chance that the person might die?
question?
For the surgery in itself, can someone die from the surgery? And what would be the percentage of fatality just for the surgery of removing that tumor at an early stage?
I see. When we assess for whether the tumor, if it is early stage, we assess not only the size of it, not only whether it has spread, but also we need to look at the patient, whether they are fit for surgery, okay? Because surgery to take out certain things in the lung, for resection, you need to open the chest. It's quite a major surgery, okay? Although you may have heard about minimally invasive surgery nowadays, that they use video scope to put in different ports, okay, like robots, okay, to resect part of the lung. But it's still major undertaking, what we call general anesthesia. So when we have patients like this, we first assess what we call the anatomy of the tumor, whether it is resectable. And then we look at the patient as a whole and assess the lung function as well as the overall function. I must say, sometimes it's unfortunate that people may be getting too old for surgery. For example, in the patients we have seen 80, 90 years of age, then the chance of him getting surgery for curative resection will be lower. I must not say it's zero, but it's lower compared to a younger person. And a lot of times we look at the lung function, and lung function sometimes can be damaged by long-term smoking. Okay? And we are a respiratory physician. We always look at patients' lung function. A lot of the times in chronic smoker, the lung function could have been damaged by tobacco smoking, what we call another disease called the chronic obstructive pulmonary disease. Bronchitis used to be the old terms. That will limit the patient's chance of having a curative surgery. So both anatomy and physiology of the patient, of the tumor, are important.
Other questions? Yes?
How can a medical student engage in research?
Sorry, you have to speak. Medical student?
Engage in
Research.
Research. I must say, nowadays we are seeing more and more medical students who would like to opt for research at the same time as they are going along the medical curriculum. And but let me share with you my story, okay? When I was undergraduate medical student, it was a 5 years curriculum. So I have to spend 5 years studying in the medical school. But at that time, there was a chance for me to study an intercalated year. That means after finishing year 3 of the medical curriculum, I opt out for 1 year to do research, and then go back to join the next class to graduate. Okay? So I spent 6 years in the undergraduate medical school doing research. In the past, when I was medical students, I was the only one in the class to do that, leaving the original class. But nowadays, it's getting more common. I must say it's not very common, but we are getting more people to do that. But I must say, this is not the only way to do or to embark on a research career. I have lots of colleagues who finished the medical school first, and then after finding the specialty they would like to practice in the subsequent career, then they identify the focus of subjects and then embark on a research career from then on. And there are just different ways of doing research in the medical field. You may do laboratory research, just like me, but it will be it will need extra commitment to go to the lab. And you may do clinical research, clinical trials that you are trying to bring new treatment, test on new treatment, test on new diagnostic strategy, just like the CT scan in my project. Okay, And you may as well do what we call epidemiological research, looking at public health issue, okay? Doing questionnaire to survey different people with respect to different aspects of the condition. So there are just vast different ways of doing research, and there are different ways of joining research career. So the different, yes?
Do you have some project will stop because you don't have enough funding?
Because of?
Not enough money, not enough funding?
Sorry, my ears.
Would any of your research projects stop because insufficient funding, insufficient money?
Fortunately, I have not encountered that before, because when we start a project, we have to make sure funding is enough before we start. So that's why it was fortunate that last year we have the TerryFox Run Hong Kong support for my project that I've set up last year, and it's started running here in Hong Kong for the past half year or so. And it's fortunate that, I won't say fortunate, for my project, we have already screened out the first subject, lung cancer, out of the initial 60 to 70 that we have screened. So hopefully we'll be able, with carrying on this project, we'll be able to get more data, understand the disease more, and at the same time help to screen more subjects and get more subjects benefited from early detection.
Yes, another question?
This is not related to cancer, but when you said you're a doctor at a hospital at
Queen Mary Hospital in Pak Phu Lam.
Yes, Queen Mary, yeah.
when you were younger, when you tried to, you're doing like surgical stuff, right? Right now?
When I was young.
Surgeon, right?
Do you do surgery as well today? Do you do surgery or?
Yes. The training structure is like this. When we were students, we have ample opportunity to go into the operating theater when we have the attachment to the surgical department. We will be able to, we won't be able to touch as students, but we will be able to observe. And then when we become what we call houseman, when we graduate, the first year of our medical practice as a houseman or house officer. And the period of 1 year will be divided into different rotations. It's still the same nowadays, okay? And it's divided into 4 main rotations, and at least one of them will be surgery. And then we have the chance to follow the qualified surgeons to do simple surgery either in the operating theater or at the bedside. We have some surgery that can be done at the bedside. And then after this 1 year of training as a house officer, then we are free to choose to apply the post that we would like to take. And I've taken physicians, so that's what we call internal medicine. Internal medicine are those physicians that will not do surgery, but with certain what we call subspecialty inside internal medicine, just like what I'm in is the respiratory field. We still have to do simple diagnostic procedure for the patients. For those what we call very, very minor surgical procedures, like sampling fluid. If the patient has got what we call accumulation of abnormal fluid in the lungs, then we have to help sample the fluid out to make a diagnosis what's to be the cause for that accumulation of water in the lung. That's usually done by the bedside, but we will never call ourselves surgeons. Okay? So a lot of times we have to collaborate with surgeons who will decide whether, for example, lung tumor can be taken out or not. And my research also relies a lot on the surgeons to help me take appropriate surgical specimen for study in the lab.
We have a question here at the front.
Please ask why you decided to pursue the medical career and like what sparked your interest in like.
Thanks for your question. Okay. Now I must say, initially I told you I did the integrated year, right? And then go back to the medical school to join the next class. I must say, at that time, I really want to do surgery. But after a year of housemanship, I indeed want to spend less time in the operating theater, but want to study more in the laboratory. So that's why I opt for the field of internal medicine and subsequently go into respiratory medicine. Whether you get into any subspecialty, it always depends on the training needs in your unit, in the unit of practice, and also whether there is a place for training. Okay? My start of the research interest actually starts from the integrated year. At that time, I was given a chance to do molecular research. That's all in the laboratory. At that time, I was not working on lung cancer, but indeed on liver cancer. So I was able to take the specimen under the supervision of my supervisor at that time and do the various molecular tests in the laboratory and find some gene mutation there. And then I go back to the medical school to complete my training and as a doctor, and then graduated and then further opt for the career of internal medicine and then respiratory medicine.
Maybe one last question, yes?
What is your opinion in sharing the state of the patient's health, sharing the actual facts with the patient? What is your opinion on that, and how much are medical students taught to have empathy and to understand the patient's perspective?
So you want to know the sharing of medical information with
Yeah,
patients?
so the state of, so I'm a cancer survivor, or I'm currently undergoing treatment. Doctors seem reluctant to share the truth with patients. And actually, I mean, the facts, you know, there seems to be a lot of doctor speak. And it's with further questioning by myself or by people I know that you actually understand your disease. There seems to be a reluctance on the part of doctors to share with the patient. So my question is more about what is your opinion on sharing information with patients so they're aware of their health? And number two, are new doctors trained to have empathy and to share with patients?
That's a good question.
And reflects the change of practice that I've experienced over the past 10-20 years. And indeed, what I in my practice is the same as what I teach my students. As you need to tell the patients the truth, but in different ways as to handle your patients according to their situation, right? First, doctors cannot tell lies to patients. Okay? You cannot say no if the patient is actually having that disease. Okay? So you have to give information, doctors has to give information in the appropriate way, depending on the patient's reception. Nowadays, in cancer patients, you do need patients to know the truth, but you need to at the same time assess their level of acceptance and understanding that they can afford. Okay? Most of the times nowadays, I must say, patients and their families know a lot before they come in. For example, even if you hint them that there is something not good, something is bad going on, they already know what it is. So there is no point trying to hide anything away. Indeed, you need to explain to the patient the true diagnosis, the exact diagnosis of what it is, because it carries implication for the subsequent diagnosis or treatment pathways that they are going to receive. And a lot of the times, as in the past, we have requests from the family members. do not tell my mother that she has got lung cancer. Please, doctors, don't say so. Okay? A lot of the times, if I can tell you, the patients themselves know what is going on. The family members are just cheating themselves. Okay? By asking doctors not to explain, not to say something in front of the doctors, actually the patients know a lot. Okay? They may, I don't know where the information is coming from, maybe it's from the neighboring bed, or maybe from, maybe from the previous family members or from previous doctors. I would say it's not a scandal to tell the patients about the exact diagnosis of cancer. We usually try to talk to the patient to see what's the level of acceptance of the patients, how she understand and give information bit by bit with the ultimate aim of letting them know the disease themselves. Unless one day we do have patients say, doctors themselves, they say, doctors, do not let me know about this. I won't care. Okay? Then we'll ask if we want to know more about what's going on. They'll say no, then we'll keep follow up until one day they ask if what kind of disease they have, then we will tell them. Okay? So that's a sometimes difficult situation. I understand that we need to handle patients in a different way, but the ultimate goal will be to let the patient know about the exact situation and the diagnosis so as to prepare them for future, because once they need a subsequent diagnostic pathway, for example, invasive investigation or surgery, or even the treatment, the chemotherapy, they need to understand the potential adverse effects or side effects they're going to get. So that's what we also tell our students about that. Information giving sometimes could be an art, but nowadays we try to give it in an appropriate way to share with the patient.
All right, we've gone over time, so we need to end the conversation. Thank you so much, Dr. Lam, for your time, your explanations, sharing your expertise. Last year, we raised over 700,000 HKD for your research project on lung cancer. So we're crossing our fingers that, today the amount is even bigger. I'm sure they'll announce the amount a little bit later. So thank you again for your time and your work. Thank you.
Thank you.